Hello, and welcome to Beyond the Bedside, Discharge Planning and Utilization Management, fostering understanding, collaboration, and engagement in frontline nurses. Introduction. When someone is asked to picture a nurse, they typically envision someone in scrubs, administering medications, running alongside a gurney as a patient is rolled into a life-saving operation. And they aren't wrong. However, the role of the nurse has expanded to include other yet equally vital responsibilities. Nurses act as caregivers, counselors, educators, coordinators, and problem solvers. They spend more time with their patients than any other interdisciplinary team member. They are uniquely positioned to deeply impact the care patients receive, which undoubtedly includes patients' transition out of the acute care setting. The following presentation will walk the nurse through their role in discharge planning and utilization management processes. Armed with a deeper understanding of these processes and how to collaborate with other members of the healthcare team to achieve the shared goal of safe and timely discharge, nurses will be better equipped to execute and engage in quality discharge planning efforts and act as responsible stewards of valuable healthcare resources. Learning objectives. Upon completion of this module, the learner will be able to understand how quality discharge planning and responsible utilization of resources aligns with the mission and vision of Valley Presbyterian Hospital. Understand the role of the RN case manager. Explain the process and relevance of both discharge planning and utilization management. Identify the ways nursing staff can actively participate in these processes. Locate case management assessments, notes, and other relevant interventions that facilitate proactive engagement in discharge planning and utilization management processes. An overview of discharge planning. Discharge planning is defined as the process of identifying and preparing for a patient's anticipated healthcare needs after they leave the hospital. Regulatory bodies, such as the Center for Medicare and Medicaid Services, regard discharge planning as one of the few indicators used to determine quality of provided care by an organization. In a value-based payment system, where providers are reimbursed based on the quality of care they provide, discharge planning also has financial implications. Quality discharge planning reduces readmissions, improving the patient's health outcomes, quality of life, and their experience of care. Overview. Utilization management. Utilization management is a set of techniques used by or on behalf of purchasers of healthcare benefits, patients, to manage healthcare costs by influencing patient care decision-making through case-by-case assessments of the appropriateness of care prior to its provision. Effective utilization management reduces unnecessary costs and increases the probability that the provider will be reimbursed. Payers determine medical necessity of episodes of care. Unfortunately, care deemed not medically necessary may be denied, with the burden of payment coming directly out of the provider or patient's pocket. Concurrent reviews are conducted by the nurse case managers at Valley Presbyterian Hospital every day. Clinical records are submitted to payers, at which point services are either authorized or denied. Utilization management encompasses providing the right service at the right time, for the right duration, at the right level of care. You may be wondering what this has to do with the bedside nurse. As an acute care hospital, we are required to render stabilizing treatment without regard for a patient's ability to pay. However, our resources are not limitless. In order to keep operating, to continue providing our community with vital care, we must be mindful of the organization's solvency. Interconnectedness of discharge planning and utilization management. Discharge planning and utilization management form an interconnected relationship. Effective discharge planning leads to earlier, safer discharges, reducing costs spent on extended lengths of stay. It also lowers the likelihood of patients experiencing post-discharge complications that could lead to readmission. Ensuring we are providing care at the appropriate level for no longer than it is required, maximizes efficiency of our care delivery. Quality discharge planning and utilization management. Alignment with Valley Presbyterian's mission and vision. At Valley Presbyterian Hospital, our vision statement is excellence in all we do. Striving for excellence is VPH's vision for the future. While broad and ambitious in its nature, our vision statement acknowledges the many changes going on at our hospital today. Excellence is defined as the quality of being excellent, exalted merit, superiority in virtue, surpassing goodness, being the very best. Proclaiming excellence in all that is done at VPH is bold and inspiring. It does not intend to say that VPH already believes it is excellent, but that the goal is to continue striving for better outcomes and to improve the quality of care provided. Our patients are only with us for a short time during admission. We address their acute ailments and discharge them home or to a lower level of care. The fact is, unless they are adequately prepared to manage their health upon return to the community, they may return unnecessarily and frequently. Additionally, our resources are wasted and reimbursement suffers. Patient health and quality of life decrease. This is where discharge planning and utilization management come into play. All members of the interdisciplinary team are vital to and responsible for these processes. Living our mission of improving the quality of health of the San Fernando Valley certainly includes ensuring safe and appropriate transitions of care. Climate change. This all sounds ideal, and you may be thinking, sure, if I had the time, I would love to discharge everyone home by noon or sit for an hour going over a patient's discharge medications with them. But that isn't reality. I don't have the time. I'm too busy. With mounting pressures from regulatory agencies to improve the quality of care at the lowest possible cost, changes are occurring at an accelerated pace. In the wake of the public health crisis of the COVID-19 pandemic, nurses are worn down. Staffing shortages are an ever-present reality. Even with nursing to patient ratio laws, the patients we see and treat are sicker than ever before. With technological advancements in medicine, people are living longer and often come to us with multiple comorbidities, not obvious if you read their admitting diagnosis. A telemetry nurse may only have 4 patients, but their acuity at times can feel like 20. Take a breath and hear this. You are not alone. You are heard, seen, and valued. You are more powerful than you think. Harnessing that power will enable you to persevere under even the direst of circumstances. Nursing does not operate in a vacuum. Healthcare is a complex system. A system is a group of interdependent individuals working together to create a whole. This whole is supposed to result in a desired outcome. It is also adaptive, meaning it is capable of learning and changing over time. It takes a village to provide quality care to the especially challenging demographic we encounter. Working with your interdisciplinary team members can help to share this burden, but understanding roles and responsibilities of these groups is required. Through knowledge and understanding of team members' roles, communication, interdependent functioning, and collaboration will follow naturally as a result. Knowing who you are working with and exactly what each person can do will lead to a stronger interdisciplinary team and practice. When discussing the topics of discharge planning and utilization management, it becomes necessary to examine the role of the nurse case manager. What is an RN case manager? RN case managers are licensed registered nurses with varying clinical backgrounds. They are a vital part of the interdisciplinary team, communicating with patients, families, nurses, doctors, and other team members to provide care that recognizes patients' needs both during and after admission. Case managers execute discharge planning, and this is often all that nurses see. But behind the scenes, and with increased pressure as a workforce, case managers are also responsible for communicating with various payer groups to facilitate reimbursement, not only for hospital services, but also to obtain needed authorization for needs at discharge. Frankly, if providers such as hospitals are not reimbursed, they risk being unable to continue operations whatsoever. Understanding the nurse case manager role, valuing them as clinical equals as fellow nurses, can foster appreciation and collaboration. Learning how to better incorporate your practice at the bedside with these care providers will help guide your participation in both discharge planning and utilization management. Nursing roles in discharge planning and utilization management. The goal of the next phase of this presentation is to show nurses how they can use the tools already at their disposal to better fulfill their roles as discharge planning and utilization management champions. The first is to review the doctor and case management notes and plan of care at least every shift. This may seem obvious, but when reviewing charts and trying to communicate with bedside staff, it is surprising to see how many nurses don't have an overarching view of what the care they are providing is for. This trickles down to patients not knowing why they are still in the hospital or when they can expect to be going home. Patients verbalize this quite often during case management assessment visits. Calls to family members frequently reveal they haven't heard from anyone, a doctor or a nurse, informing them how their family member is doing and what is being done for them. By understanding the basic plan of care and communicating this to patients and their family members, patient experience in this area will improve. Nurse communication and patient understanding of the discharge plan are both quality measures reported to regulatory agencies to gauge an organization's performance. This ties in with the next point, to assess and advocate for patients' needs. A simple example would be a patient who has been in bed since admission. They are documented as being weak or having had multiple falls at home. In an effort to maintain safety or decrease falls in the hospital, nursing may have limited their time out of bed. One way to advocate for these patients is to request a physical therapy evaluation from the doctor early on in admission. Also, be mindful of patients being transferred from other floors, such as ICU or med-surg. Physical therapy stops assessments per their protocol if there is a change in condition. They require a new evaluation order to be placed before they can resume care. Nursing can then rely on the expertise of their physical therapist teammates to decide whether they can and should be getting out of bed and the level of assistance that's needed. Another way nurses can assist the interdisciplinary team with discharge planning is documenting family or next of kin information in the EMR. If you see a visitor or receive a call from someone inquiring about the patient, jot down their name, relation to the patient, and contact information. Face sheets frequently do not reflect current demographic information or updated contact information for decision makers. The plan of care gets stalled. Consent may be needed and the team can't contact anyone. Asking a couple of questions and making this information available can expedite the discharge planning process and improve timely provisions of care. Next, consider throughput when holding a discharge or transfer order. While this may not be intentional, nurses may have inadvertently dismissed a discharge order to catch up on their more acutely ill patients. I'd like you to take a second to think about the bigger picture. A patient has been waiting in the emergency room for over 24 hours for a telemetry bed. They're in pain, in a busy, noisy environment. Their back hurts from laying on an uncomfortable gurney, and they haven't eaten. Eventually, this can happen several more times, and now the ER is on diversion. Ambulances are diverted from bringing patients to our hospital because we simply don't have anywhere to put them. The patient must be transported farther away to obtain needed care and may suffer negative health outcomes as a result. This illustrates the domino effect that one action or inaction can have on the entire system. Patients who are alert and oriented, ambulatory, and safe may be discharged with the hospital-funded Butterfly transportation system. There should be no reason to wait for a family member to pick the patient up unless they do not have access to the home or it is unsafe. Code ABC. As outlined in Valley Presbyterian's policy, a Code ABC stands for Code All Bed Crisis. Initiating a Code ABC serves to provide a consistent process for meeting patient care needs and maximizing patient throughput when capacity nears or exceeds available staffed beds. It is an alert mechanism for notifying staff that there is a situation requiring problem solving for expediting patient placement and care. The operations supervisor makes the decision to announce a Code ABC when the hospital nears or meets a critical or near critical capacity. A representative from case management and the various nursing units are to report. The goal is to discuss any impending discharges or transfers and expedite these as possible to be able to meet the needs for incoming patients. While nurses are not expected to respond to this code, there are actions nursing staff can take to help improve throughput and patient flow. First, become aware that the hospital is experiencing a high volume of patients, and it is affecting our ability to render timely care to people presenting to our hospital. Second, review your patient assignment and discuss the possibility of downgrading a patient with the respective provider. Lastly, if any of your patients have active discharge orders, work to discharge them as soon as you are reasonably able to avoid critical delays in provisions of care. Another vital way nurses can participate in discharge planning and prevent unnecessary readmissions is by taking time to educate patients regarding their home medications, needed and recommended follow-up care, and signs or symptoms that may indicate a medical emergency, as well as those that do not. Knowing what to expect for their recovery is crucial in enabling patients to manage their health independently. Nurses can also actively intervene with existing nurse-driven protocols to prepare the patient for discharge and avoid unnecessary delays. Examples include weaning patients on minimal oxygen requirements to prevent this delaying discharge. If a doctor does order home oxygen, take the initiative to assess and document the room air oxygen saturation level. Keep in mind that patients must desaturate to 88% on room air or less for insurance companies to authorize the equipment. Another frequent barrier to timely discharge is patients receiving hemodialysis. Nurses are required to contact DaVita to confirm dialysis scheduling the day before treatment, with the exception of stat orders. Reviewing the MD and CM notes will have given the nurse insight into whether the patient has a chance of going home the next day. Mention this to the dialysis team so the patient can be prioritized the following day. Keep in mind, the hospital is not reimbursed for services on the day of discharge, so assessing for discharge readiness on a non-treatment day would be even better. Finally, assess the patient's appropriateness for current level of care every shift and with changes in condition. Can the patient be downgraded? Is the patient listed as observation when they meet inpatient criteria? Wait, what are inpatient criteria? What does that mean? Now, patients may be admitted under observation when ruling out an acute process. On telemetry, these are often seen as patients being ruled out for stroke or acute coronary syndrome. In general, patients with a definitive diagnosis receiving treatment not available outside the hospital meet requirements for inpatient status. Confirm this with your case manager. They will be excited to see your engagement in the utilization management process. And here is why this distinction is important to all of us. Telemetry patients admitted as inpatient are charged accordingly. Observation rates are considerably lower. All of us could agree that our organization should be compensated appropriately for the care and hard work we are doing, and the supplies we are using. Keep this in mind, and you'll be on the way to doing your part in utilization management. Meditech discharge planning assessments and interventions. This slide quickly illustrates where in the electronic medical record nurses can access the case management notes. Case management notes are located in the EMR under the Notes section entitled Care Coordinator. To drive this idea home, reviewing the notes allows nurses to communicate progress with patients and families. It empowers nurses to anticipate discharge. It improves workflow by reducing the nurse's need to call the case manager when busy trying to get the patient discharged or render care to other patients. With many temporary or newly hired staff, it may not be something that the nurse is aware of. In order to review the plan for discharge, you have to know where to find this information. Before asking the case manager to save time, take a look at the notes. They may hold more answers than you think. If you still have a question after reviewing the notes, your nurse case managers are always available and happy to discuss this with you. Incorporating discharge planning and utilization management into your daily work. Assessing, planning, communicating, and intervening. Participating in discharge planning and utilization management will become second nature as it is incorporated into your daily work and thought processes. By assessing patients early on and throughout admission, the bedside nurse can identify potential barriers to discharge in a way other team members aren't able to. With this information, they can use their clinical knowledge to determine the next indicated step. Whether it is requesting a physical therapy evaluation or slowly titrating down that oxygen, the nurse becomes a pivotal decision maker in how long patients stay in the hospital. They can reach out to their teammates, such as doctors and case managers, to plan next steps. Intervening in these ways, nurses can help facilitate the discharge and ultimately the healing process. Conclusion. This presentation has hopefully provided insight into the multifaceted aspects of discharge planning and utilization management. Nurses possess a combination of clinical expertise and frequent patient contact to heavily influence the efficiency and quality of patients' transition back to the community. Through communication, collaboration, engagement, and a broader systems-based approach, both nurse and patient experiences will improve. This is an example of a synergistic relationship, the results of multiple parts working together to achieve goals and overcome obstacles. Synergy is what happens when 1 + 1 = 10, or 100, or 1,000. It's the profound result when two or more respectful human beings determine to go beyond their preconceived ideas to meet a great challenge. Our challenge is great, but so are we.